I'm Randall Reeves from Denver, Colorado, and I want to thank all of you for coming to this session, and particularly for the presenters for putting together these abstracts that we'll be eagerly waiting to hear the results of. So each presenter has about 8 minutes and 3 minutes for discussion after that if we have time, and we'll need to wrap this up at 3 o'clock. So again, thank you very much for coming. I'd like to introduce the first presentation by Ramnath Subramanian, the Tuberculosis Cascade of Care in the Indian Public Sector, Current Estimates and Gaps in Knowledge. Thank you very much. Okay.
All right. Thank you. I feel privileged to be able to present this on behalf of my co-authors. So this is a collaboration across India, Canada, and the US of different researchers. Just to acknowledge our funders very quickly, of which there are many. I would just point out the Fogarty International Center, which gave me a fellowship last year. So the Cascade of Care model is well known to people in the HIV community. It's also often referred to as the continuum of care, and it helps to visualize gaps in care delivery. And it's widely used to assess HIV outcomes both locally and globally. And in fact, it undergirds UNAIDS 90-90-90 global HIV targets. And yet it's not been widely used to monitor tuberculosis programs. So we created a Cascade model that integrates concepts from the HIV Cascade of Care with the WHO onion peel TB model for program monitoring, which has been on occasion or rarely used actually. And we present here the Indian Public Sector Cascade of Care for 2013. So this is our model. I'm not going to walk you through this. I'll walk you through this simplified one. So of the number of prevalent TB patients in India in 2013, we estimated the number of TB patients who were evaluated at TB diagnostic centers, the number successfully diagnosed, the number registered in TB treatment, the number who completed treatment, and the number who achieved 1-year TB recurrence-free survival. And we used 1-year TB recurrence-free survival as the patient-oriented outcome of this cascade because we think it's a better outcome than treatment completion. And when you see the cascade, I think you'll understand why. And I would just point out that number registered in TB treatment and number who completed treatment are really the known universe of program indicators for most countries. So the methods, we extracted data from a variety of sources. The WHO Global TB reports for some burden of disease estimates, the Government of India TB India reports, which are their annual status reports with statistics broken down for different types of TB, and other indicators we estimated by systematic reviews and meta-analyses of Indian studies from 2000 to 2015. And some indicators were extrapolated from relatively recent single nationally representative studies. So the paper was just recently published. There are actually 4 appendices of systematic reviews. To summarize, out of 6,000 abstracts, we identified 39 relevant studies and extracted data on 5 gaps, which I won't go through, but they'll become evident later on. So this is just one of the gaps. There are several forest plots that informed our estimates. This is pretreatment loss to follow-up. That is patients who are successfully diagnosed but don't get registered in treatment. And across 14 studies that have been published on this, we did a random effects meta-analysis and found that about 16% of patients across these studies were diagnosed but not successfully started on treatment. And just to give you some other results from our meta-analysis before moving to the cascades, there are very few studies on treatment relapse in programmatic conditions as opposed to clinical trials. For new smear positive patients, there's about a 16% relapse. For smear negative and extrapulmonary patients, there's about a 9% relapse. And for retreatment smear positive patients, that is those with a prior history of TB, there's about a 27% relapse rate. Now to the cascade. So this is the cascade of care for India for all forms of TB in the year 2013. Out of 2.7 million patients, prevalent patients estimated in 2013, about 1.9 million, or 72%, were estimated to have reached government TB diagnostic centers. 1.6 million of those were estimated to have been successfully diagnosed with TB, which is about 60% of the overall number. 1.4 million were registered for treatment, which is about 53%. 1.2 million were completed treatment, which is about 40%, and about 1 million patients, or 39% of the overall population of 2.7 million patients in 2013 were estimated to achieve 1-year recurrence-free survival. And the gaps here are implied in the drop-offs in the bar graphs. So about 760,000 patients, or 20% of the overall population of TB patients, never seek or reach government TB care. About 300,000 patients, or 11%, seek government care and make it to a TB diagnostic center but are not successfully diagnosed. About 200,000 patients are successfully diagnosed but not registered in treatment. And I would just point out, if you take two of these gaps together, those who reached government TB centers to those who got registered in treatment, those two gaps together suggest that about 500,000 patients make it to Indian government diagnostic microscopy centers but are never successfully started on treatment. So we actually also did this by type of TB. We actually had to do it by individual form of TB to aggregate the estimates to get the national estimates. And I'll run through some of these subcascades very quickly. For new smear positive patients, there were three major gaps. About 100,000 patients were successfully diagnosed but not started on treatment. About 74,000 patients were lost to follow-up or died on treatment. And about 88,000 patients experienced TB relapse or death. And the central point I'd like to point out here is the known universe is the 74,000 who died or are lost to follow-up on treatment. And yet, the gap before and the gap after are actually substantially larger than what we know about where TB patients are being lost. In other words, more patients are being lost up after diagnosis and before starting treatment than are lost during the entire 6-month course of treatment for the largest population of TB patients in the program. For retreatment smear-positive patients, about 51,000 failed, died, or were lost to follow-up on treatment, and about 34,000 experienced TB relapse or death. And these are the two biggest gaps for this form of TB. They suggest underlying problems in either in treatment adherence or in diagnosis, such there may be drug-resistant cases who are experiencing very high relapse rates. For new smear negative patients, about 193,000 patients are evaluated at diagnostic facilities but go undiagnosed. This is by far the biggest gap. It speaks to the broad-scale underlying use of smear microscopy and the fact that most patients, about 60 to 80% of patients, don't make it through the diagnostic algorithm for smear-negative TB. For the MDR TB cascade, and I think this is the most striking figure of our work, out of 61,000 patients who reached government diagnostic facilities, ultimately 11% had the optimal outcome of recurrence-free survival. And about 59% of all patients never got successfully diagnosed by our estimates. And that's by far the biggest gap out of multiple very substantial gaps in the MDR TB cascade of care. So just to summarize our main findings, about 39% of all prevalent TB patients in India reach government centers and in the government program achieve 1-year recurrence-free survival. This proportion may be lower with the upward revision of India's TB estimates in the last 2 weeks by the WHO. About 500,000 TB patients reach government TB services but are not successfully diagnosed or started on treatment. And pre-treatment loss to follow-up, those who are diagnosed but never started on treatment, is a larger gap than patients lost during the entire treatment course. I won't go through the sub-cascade points, I discussed them. I would just say that post-treatment TB relapse is a major gap for all patients, and one recommendation out of this is 1-year follow-up of all TB patients in the entire program might actually be the best, most efficient mode of active case finding that we know. A final thought, the Cascade model was a paradigm shift for the HIV community. It really helped to point out gaps that were not discussed previously. It helped to target interventions. It now undergirds the entire global strategy for HIV, and I think similar Cascade-based national targets and analyses should be considered in our field. Thanks.
Yeah, thank you very much. I think we might have time for one quick question, and we'll go on to the next session. Okay.
So we did that through a variety of methods.
I'm sorry, would you just briefly repeat the question?
So the question was, how did we get an estimate of those who reached diagnostic facilities, true TB patients, who reached diagnostic facilities were not successfully diagnosed? It's a challenging gap to get. It was different for each form of TB. For smear-positive patients, the assumption was that the proportion who didn't give a second smear gives us some estimate, knowing how efficient the smear is for those who might be missed if they had a negative first smear. and we estimated it for smear-positive TB that way. It was a relatively small gap. For smear-negative TB, there was a recent rollout of Excerpt across multiple sites in India, and that study actually, because it was a pilot study that actually included multiple sites all over the country, gives us an estimate of how much smear-negative TB we're missing. And that was actually one of the ways that we were able to estimate that smear-negative gap and show that it's actually quite large if you're just using smear microscopy alone in the current system.
Okay, thank you very much. I think we can see we have a lot of work to do toward ending TB, so thank you for really showing the gaps. Okay, the next paper will be presented by Wheelie Sekonzi from Swaziland, and the title of the paper is An Assessment of TB Screening to Treatment Cascade in Swaziland. Thank you.
Thank you very much. I'm presenting on behalf of a team from the NTCP and CHI. We've been working on a cascade analysis looking at qualitative and quantitative factors resulting in leakages within the cascade. So just some background epidemiology, that Swaziland has one of the highest incidence rates of TB globally, and unfortunately there's also a suboptimal case detection rate of 60% and a significant MDR TB burden. So this really resulted in us reviewing the cascade to identify leakages in the screening to cure cascade that are leading to the loss of follow-up of patients along the pathway. So it was a mixed method study which included triangulation of qualitative and quantitative data. For our quantitative data, we used 11 national level M&E data sets, including laboratory data sets. And we aggregated data. We used aggregate data from the data sets compiled from patients screened in 2013. And this was to allow for us to assess treatment outcomes at the end of 2014, of which outcomes are assigned in 2015 at national level. Data was analyzed using Microsoft. And then at facility level, it was more for qualitative assessments for a sample of 63 facilities out of 110. We included all the peripheral laboratories at the time that were conducting gene expert testing, as well as the National TB Reference Laboratory. And at each facility, a questionnaire was administered to a healthcare worker and a laboratory technician to assess the clinical laboratory interface at that facility level. So this is the optimal cascade in Swaziland. It's quite similar for all countries implementing TB programs in which patients are screened for TB symptoms. Those that are positive ideally should have samples collected. We use gene experts as the initial diagnostic test since 2012 for all presumptive TB cases, regardless of their HIV status or history of previous treatment. And then we have an expanded access to DST algorithm, which allows for all MTB positive samples to be sent to the NTRL for first-line DST, and those that are found to be rifampicin resistant on gene experts undergo second-line DST as well from the beginning. So we were using this as our benchmark for assessing the cascade and identifying leakages in the cascade, as well as adherence to the national diagnostic algorithm. So patients who are found to be MTB positive, a sample is sent to the NTRL for culture, LPA, and drug susceptibility testing. And at the same time, obviously, patients are initiated on the appropriate treatment. And we hope that there'll be a treatment or a regimen change based on results returning from the NTRL. And then outcomes are assigned at the end of their treatment period and or reported to the NTCP within 6 months of that assignment of the outcome. So major gaps that were identified at each stage of the cascade, going from screening, there was a challenge identified in terms of reporting from facilities, and within one facility, reporting of screening activities from different areas within the facility. We only had 22% of our facilities reporting regularly on screening data. And then we also found that there was a gap in terms of when patients are screened positive and should be assigned or included into the presumptive TB register. There was a huge gap in terms of those that screen positive and those who are actually recorded in the presumptive TB register, where less than 50% of our patients are then included in the presumptive TB register, because our healthcare workers will wait for a patient to return to the facility with a sputum sample before including them in the presumptive register. We then looked at sample collection as a proxy for adherence to the national diagnostic algorithm, in which As implementation of the national diagnostic algorithm requires for 2 samples to be collected, we were assessing whether that is indeed the case. Majority are not collecting those 2 samples. 23% are collecting 1 sample. And majority of the facilities or the patients report not requesting gene experts or requesting gene experts as well as another test like microscopy or chest x-ray. One of the main contributing factors to lack of adherence to the national diagnostic algorithm goes hand in hand with poor infrastructure or weak infrastructure at facility level, which does not allow for infection prevention and control measures to be adhered to when it comes to sputum collection. So a majority of patients are sent back home and are then requested to collect their sputum at home and to return to the facility with their sputa before TB testing can be undertaken. And we found that to be one of the challenges resulting in the initial loss to follow-up. Even though Gene Expert was adapted as the initial diagnostic test in 2012 for all patients, we found that less than 50% of patients initiated on treatment have actually undergone TB testing or have received any form of bacteriological confirmation prior to treatment initiation. And the main challenge for us was trying to strengthen or bring together the laboratory and the clinic in terms of strengthening the TB clinical laboratory interface in terms of adherence to the algorithm for samples to being sent to the peripheral laboratory and follow-up of results as well as follow-up of patients and bringing patients back into care who require treatment initiation post-receival of their gene experts or culture and DST results. One challenge that we do face, and I think this is common to most NTPs, is the assignment of treatment outcomes for patients in whom we are unable to confirm a cure. So there's no bacteriological confirmation that this patient has indeed been cured. A lot of our patients are just completed treatments, and that is understandable given the nature of the disease. But what was a real concern for us at the time was about 48% of our MDR TB cases were initiated on treatments regardless of there being a culture and DST result. And this goes back to the rapid introduction of gene experts at the time, which in a sense for a year and a half, almost 2 years, replaced the need for healthcare workers to send samples to the NTLP for follow-up testing. I think with the way that Gene Expert was implemented in a lot of countries, it was a rapid scale-up process, and without allowing for sufficient time for capacity building, as well as recording and reporting tools to capture results, and to ensure that healthcare workers fully understand that Gene Experts is the first step in the diagnostic algorithm, but there is still a need for follow-up phenotypic testing for full resistance profiling. So we had a lot of patients who were initiated based simply on their Gene Expert results, or on rifampicin resistance, and no culture and DST results available for them. And this could have contributed to the high loss to follow-up we identified at the time. So some of the measures that have been taken to address the gaps included refurbishment of some of the facilities to improve the infrastructure to allow for on-site sputum collection. The national diagnostic algorithm was revised to ensure all MTB positive samples or all MTB positive tests were then followed through with culture and DST for first line and then second line for the RRs, which goes hand in hand with training and capacity building of both the clinicians and the laboratory personnel, ideally in a single sitting, which we found to be quite challenging, but also eye-opening in some of the challenges that were raised by both sides of the cascade. We also, with the support of CHAI, have conducted a Gene Expert optimization analysis, which we have used to identify where additional Gene Expert machines should be placed based on the burden of disease or the burden of TB patients in those areas, accessing services in those facilities. And we've conducted 2 TB laboratory network capacity assessments, looking mainly at the national sample transportation system and quality indicators like turnaround time from sample collection to treatment initiation. And these are some of the activities towards strengthening of the clinical laboratory interface that we have undertaken, as well as ensuring that we have connected devices or connectivity for our Gene Expert machines for real-time monitoring of TB testing in the country, and linking this to our immediate disease notification system at national level for all DR/TB patients. So in conclusion, the analysis it's a baseline. It was the beginning of what we hope will be regular cascade analyses, not just of quantitative data, but a lot of the qualitative information that came through really helped in terms of speaking to the gaps and identifying some of the bottlenecks that are not highlighted at national level when you are looking at aggregate data. So this information has been used in terms of our resource mobilization and identifying additional activities that require funding for TB laboratory strengthening in the country. We've implemented targeted interventions to address these key programmatic gaps, and we are working on developing an integrated and holistic approach to programmatic management of TB in the country. Especially more often than not, we find there's a need for settings or quality review meetings in which both the healthcare workers and the laboratories are discussing data on a regular basis, on a quarterly basis. This was the first cascade assessment, which allows the NTP to identify weaknesses at all levels across the TB cascade, but we surely do hope that moving forward, these will be conducted on a more regular basis, as it has really opened up areas that require further strengthening towards improving case detection in the country. Thank you.
Thank you again for an excellent presentation. We do have time. Why don't we take one question or comment if there's anyone that has one? We'll have some time to talk to you in more detail later. So thank you very much. Okay, the next paper is by Nobly No from Zimbabwe, and the title of the presentation is Making Sense of Tuberculosis Data, How District and Facility Staff Can Use Their Own Routine Data for Management. Thank you.
Failing to get us?
Hello? Did you get that? Okay, just a second.
Okay. All right, good afternoon. My name is Law.
Yeah, I couldn't say that. Thank you for doing that.
It's a click name, yeah.
I even practiced a couple of times, but I couldn't quite get there.
Yes, I work for the union in Zimbabwe under the Challenge TB program. 2 seconds.
Feel free to go ahead and make a few comments while he's looking for your slides if you like. Or if you want to wait, that's fine too. Yeah.
All right, so I'm honored to give this presentation on behalf of my colleagues from the union and the National TB Control Program. The title of my paper is Making Sense of TB Data, How Facilities and Districts Can Utilize Their Own Data at Local Level for Decision Making to improve TB program management. This was a pilot which was done in 3 districts of Zimbabwe, having realized as the NTP that facilities were just, districts were just reporting data to the next level passively without really having to critically look at the data and analyze it to improve program performance. So this approach was actually a brainchild of NTP together with the union, Challenge TB, and TB Care Support. In 2009, but it took some time for the approach to be developed, and it was actually piloted in 2012 in Zimbabwe. I'm going to finish the presentation. I hope it's coming up now.
Going to work this time? Okay.
Maybe I should continue and finish.
I'm so sorry.
Nothing? Should I continue? Would have been good to.
It's just, do you have a sense of whether this file is going to be loaded?
Wow, thank you.
Thank you very much. Thank you.
So like I've said, these are some of my colleagues from the union and from the NTP in Zimbabwe. Next. Unfortunately, I can't use, so I'll be asking you to go to the next slide. Yeah. So my focus of this paper is to present the impact following this intervention on strengthening local use of data in 3 districts in Zimbabwe. Next slide, please. As you all know, that recording and reporting, supportive supervision were a very critical components of the DOS strategy, which was developed by the union in the 1980s. And it also featured significantly in the Stop TB strategy. And also in the NTB strategy, there is increasing concern over the quality of data. Next slide, please. So as part of this approach, by the NTP and the union, a new facility quarterly report was introduced. And prior to this report, what used to happen was that we had one district TB register, and the reporting started at district level. So the facilities would just record the patients that they were managing. So in this instance, a new facility report was introduced, and with this facility report, it was a one-page document, a list of short indicators focusing on presumptive TB, MDR TB, HIV treatment outcomes, and DOT and drug management. So following the introduction of this facility report, the healthcare workers were trained on how to extract data from the registers into the facility report and to go on further and tabulate the data and analyze the data, looking at the trends and also comparing against the average district performance and picking out key challenges, strengths, and weaknesses. This was done at local level by the facility healthcare workers. And there was a lot of support supervision done by the district and by the province to the facilities focusing on data. We call it data-driven support supervision visits, where the members from the district will get to the facilities and look at the data from the information from the registers, tabulate the data together with the facilities, and identify key strengths and weaknesses using these key indicators identified. Next slide, please. So this is how the report looked like. This is the upper page. It focused on data from the presumptive TB registers, looking at the number of presumptive TB cases identified, number with sputum sent to the lab, number with results, number with positive results, and disaggregated by microscopy and GeneSpect, and then also number of presumptive TB cases tested for HIV and number with HIV positive results. Because Zimbabwe is a high HIV TB burden. And then it looked also at the TB cases diagnosed in the registers, looking at the pulmonary and all TB cases, and also the HIV testing and ART and CPT initiation for these TB cases diagnosed, and also the type of DOT for the patients that were started on treatment. Next slide. And then the lower half also looked at the treatment outcomes and for those that had completed the treatment, and then the TB HIV activities, and also type of DOTs. And also looked at the drug management, drug stock levels, and the expiry date. So it was just a one page. So the top one is the upper patch and the lower patch. Next slide. So this is an example of how the facilities were taught or tabulated their own data. They would look at, if you look at the rows, the first column, they would look at their data quarter by quarter or year by year, and do a cascade like what my previous colleagues have presented, number of presumptive TB cases identified, number of sputum sent to the lab, number of expert or smear results, number of positive smear or expert results, number of HIV test results, and number of HIV positive results. So having done this, they would be able to identify where in this cascade patients would be lost. And this is done at the local facilities by the local nurses, the local team, and then they'll be able to pick up strengths and weaknesses. For example, if you look at all 2012, they had identified this facility 86 patients, presumptive TB clients, and only 78 had sputum sent to the lab, and 74 had results received. Then they would sit down and discuss, why is there a gap in this? What happened to the other patients that we did not send the specimen to the lab? What happened with other patients that we did not receive results? So in this case, the facility members began to query this and to take action, unlike previously where somebody else would come from outside and just get names and go and compile the report at district level. But now they were utilizing their data at local level to find gaps and come up with local solutions. Next slide. Next slide. So this is just one of the examples that I have given with the limited time that is available. But they would do these kind of tables for case finding, for treatment outcomes, for TB, HIV. So then they would tabulate, after having looked at the tables, then they will come up with a list of strengths and a list of weaknesses and identify which of the indicators were weaknesses and which of the indicators were strengths. For those that had weaknesses, then they would come up with action points where they could to address those weaknesses. These are just examples of what they could do. For example, clinic staff should ensure that TB screening is practiced in OPD and OI clinic. Having noted that maybe the number of presumptive TB patients identified in that area were fewer than the other areas. And then they would allocate the person to do that and come up with specific time-framed recommendations to address the gaps. Next slide. So in the district that had full implementation of this, we tried to look at the data before the intervention and after the intervention, and also comparing with what happened in the province. One of the indicators was presumptive TB cases per 100,000, and in the provinces, it increased by 40%, and in the particular district where the pilot was, it increased by 77%. And then new smear positive TB per 100,000, it increased by 2% in the province and in the district by 103%. And those pulmonary TB patients with smear not done, it decreased by 23%. And in the province, in the particular district, it decreased by 77%. In the RT coverage, increased by 76% in the province and increased by 74% in the pilot district. And loss to follow-up decreased by 25% in the province and decreased by 57% in the pilot district. Next slide. So we concluded that the pilot data suggests that data quality and program performance have been strengthened in the districts where there was this ongoing pilot, probably owing to the fact that the local health workers could take action, could analyze their own data, and if you are using your data, then you become interested in the quality of the data that you use. The new approach makes better use of routine TB data for management, promotes quick, simple, and comprehensive on-site assessment. We're talking about Cascade here, but in this instance, it was done by local health workers at local level. And it also motivates them, and they own the TB data in the program at that level. And NTPs and partners should promote the approach and also consider using it in other programs, contributing to strengthening the health systems and implementation of the NTP program. We've also realized that in Zimbabwe, the facilities are becoming to analyze even other data from other programs because of the concept is just the same that they have learned from the TB program. Next slide. Before I talk about the conflict, we've also, going forward, the country has actually adopted this approach. All facilities are now compiling reports and analyzing data in Zimbabwe. And this was part of the postgraduate course that we shared yesterday as a country on how this has gone along, and hope that other countries will also take it up. And also we have recently introduced DHIS2, and we hope it is going to make it easier for the facilities and districts to tabulate their data. Thank you very much.
Yeah, thank you for that excellent paper and for working your way through the challenges. Why don't we take time for one question or comment?
So I think that's outstanding work. I mean, I find that in the field, a lot of the problems are really data problems of missing addresses, missing phone numbers, and just huge numbers of patients get lost from these simple, missing information in registers. How do you feel like it was the monitoring that really made a difference? Just the fact that they were, data would have to be periodically collected, or do you feel like it was really the actions that came out of the discussions that really brought about the results? If you feel it was the fact that people knew they were being monitored at some level. What do you think?
You might need to repeat just a bit of the question to the audience.
Thank you. I think the question says, do I think that it was because of the monitoring at the health facility that improved the data quality, or it was because of the external support, if you're coming to the facilities time and again, that really on its own can make an improvement? Yeah, maybe I should say both. Yeah, but as time went on, we realized that the facilities were really getting interested in their own data, making a story out of what they were collecting. But initially, of course, it was, you are there, you're pushing them. It took some time for them to really understand, especially when you start seeing the results, you are comparing with the previous quarters, and you are seeing an improvement in what we have been doing. That in itself motivates you. You get more interest in the program. So I would say it was both, but as time went on, there was really a change in the ownership and interest and motivation for the local staff.
Okay, thank you very much. Thank you.
Thank you, Chairperson. I am representing Dr. Muluka Malasa. He was not able to attend due to visa problem. So as stated earlier, our focus is on system strengthening. How can we improve health program implementation through system strengthening? Although we didn't relate it with patient treatment outcome, at least we can show our achievement in terms of achieving the process indicator, namely drug stock out. It's a USAID funded project, and actually it's a closed project. We have been working there for 5 years, and I'm presenting our achievement over 5 years. These are the co-authors, and the principal investigator was Dr. Mulukan. I also concur, with the Zimbabwe experience. We are using our available data for decision making, and that's how we improved our drug stock out through our local data use. This is just a general background. As you all know, stock out is likely to be related with interruption of treatment from our previous experience, and it might also predispose to drug resistance due to interruption of medications. And in our setting, we are thinking that implementing a good pharmaceutical logistic management system might improve our availability of drug and ultimately treatment outcome for our patients. So we are presenting our experience in achieving near to zero anti-TB stock out rate in 2 regions of Ethiopia, which is a total of 50 million population. To highlight some of the interventions, earlier on, our IPLS or pharmaceutical logistics system was not that strong. And with the advent of our project and in collaboration with our national partners, specifically the National TB program, we implemented an integrated pharmaceutical logistics system. It's a one-way system of reporting as well as requesting drugs. So we sort of integrated the requesting reporting into one system in terms of drugs. And through our project, a total of 3,424 healthcare workers were trained in IPLS over 5 years. And we also distributed standard operating procedures on IPLS, as well as recording and reporting tool. As mentioned earlier, on quarterly basis, we have district medical officers who provide technical support to health facilities. And one of the components of the technical support is on IPLS. Because our health facilities, they have to use the recording and reporting mechanism that was created by the National TB program. There are two types of recording and reporting tools. One is IFRR, which is Internal Facility Report and Resupply Report. And the second one is RRF. The internal one is, where the TB clinic requests for medication from the drug score within the health facility. And the second one is RRF, which is Report and Requisition Form, which is the health facility requesting drug from the National TB program or Regional TB program. So IPLS improved drug supply management by way of integrating drug requisition, distribution, and reporting into a single mechanism. These are some of the results. Earlier on, we were using, tracer drugs, especially adult anti-TB drugs, RHZE and RH, to track, our stock out in the health facilities. We have used the adult medications because they are the ones that are widely used by our patients. And as you can see, the stock out, of adult anti-TB drugs improved, from 22%. It used to be 22% some 5 years back. And through the implementation of IPLS, it reduced to 2.4%. And most of the 2.4%, as you can see, we're implementing in over 3,000 health facilities. And if you consider 2.4%, there are few of those health facilities. And some of them are due to security problem and distant issues. If you see up-to-date stock card, it used to be around a quarter at the beginning. And recently, almost 4/5 of our health facilities are regularly updating their stock card. And if you see the use of, those recording and reporting tools, in the first year of our project, it was only 11% of, the facilities who were using the internal requisition form. But by the end of our project, almost 94% of them are using the requisition and reporting forms properly. Although we couldn't relate it with, treatment outcome, we are saying, we have at least improved the process indicator, namely, the usage of those forms and drug stock out, which is highly likely to be related with better treatment outcome. So in conclusion, the use of, standard integrated pharmaceutical logistics system and regular district-based mentoring contributed to our significant improvement in anti-TB drug stock out, and it should be expanded to other programs. We are using it for TB as well as other programs, but when it comes to, the quarterly supervision, it is not happening with other programs. It's only with the TB program that we have regular mentorship. So we are recommending that it has to be also, the mentorship should be coupled with instituting the IPLS system. I think this is what we have, and thank you very much.
Yeah, thank you for another excellent report. We have time for questions or comments. Yes. Yes, so the question is whether the mentoring was more important, or was it the system set up to measure the outcomes?
Yeah, we didn't specifically, assess those things, but the way we see it, they have, a sort of synchronizing effect to each other. But if you see IPLS, it's also implemented for other health programs. What we will do afterwards is to compare, drug stockout between tuberculosis versus other programs who are not having regular mentorship, and we'll do that and present it.
I guess one question might be, how effective could the mentoring be if you were unable to measure the stockout issues and so forth?
Yeah.
I mean, does the system allow you to do more effective targeting mentoring or not? I don't know.
Yeah, our mentorship, just like the Zimbabwean experience, it's more of, comprehensive. Mm-hmm. We mentor on case finding. We also mentor on drug stockout, TB infection control. There are a number of, laboratory-related issues. Otherwise, for TB program, we can't have, standalone mentorship. It has to be comprehensive. And in fact, we are planning to make it a national tool. And even other countries are also going to use, our best experience. But it's also worth exploring, what specific element is contributing for the outcome. And it's a good comment from our colleague here.
Okay, thank you very much. The next paper is from Uganda, being presented by Mary Mudiope, and the title of the paper is Subnational Rationalization of Integrated HIV/AIDS TB Partners Could Increase Funding for TB Programs, a Case for Uganda. Thank you.
Good afternoon. I'm presenting a paper on subnational rationalization of integrated HIV/AIDS TB services partners, which could mean increased funding for TB programs. This is a case for one of the regions that IDI, Infectious Diseases Institute, that supports, that is Midwestern Uganda, and we tried to integrate the TB services in the already comprehensive HIV services, and we looked at costs, what it would mean to integrate the TB services in the HIV programs. So generally, as you have heard before, in the previous sessions we have had, the TB program is faced with funding gaps, which are wide, and we are not getting any new partners that are supporting only TB services. But also in Uganda, we also have very limited domestic funding. Global Fund is also known as one of the major funding sources for the TB programs. But also we know PEPFAR is available to support the HIV programs. And in Uganda, PEPFAR supports most of the HIV work in Uganda. So, however, that program is challenged with the tracking of the resources from the different sources that we have. Some of the examples have been given before, and you can see from there the funding gap, which is highlighted in green, that we always face as a country. So what about this rationalization? In 2012, the PEPFAR started up the rationalization with the objective of reducing duplication of efforts. And here, one comprehensive HIV partner supports implementation of the HIV TB services in a defined geographical area. And in 2015, PEPFAR subgranted IDI to accelerate comprehensive HIV response in Midwestern Uganda. And what I'm going to present here is from that region for the 6 to 7 months that we have tried to integrate the TB services in this program. So what have we done so far to see that we integrate? We have had human resource committed to TB HIV response, and here we have the HIV TB advisor and 4 TB HIV technical staff based in the field. We have also supported development and operationalization of annual plans, integrated annual plans for TB and HIV, so that districts have plans that have TB components in them, but they're actually HIV plans. We have also supported capacity building of district and facility teams in TB HIV, and this covers all health workers in the health facilities. We have also supported monitoring and performance of key TB HIV program indicators at all levels in line with the strategic plan for the national program. And from August 2015 to Feb, you can see some of the things that have happened in that time. We picked the Gene Expert because it covers both HIV and TB, and from there, before September, we had data on Gene Expert. In the region, we had 5 Gene Expert machines, but the national program did not have much of the information, what is going on there. So we're able to support reporting of that data, what is happening in each of the Gene Expert sites. And you can see also the numbers are increasing. The blue bar is talking about the Gene Expert sites, the data that was coming in through. The first quarter, we were able to have all the 5 Gene Expert machines report, and they could not disaggregate whether that data is from that site or from other sites in the region. The following quarter, you can see that the samples increased. You have to add the blue and red bar, but also we're able to pick those which are resistant, and also able to pick the DSTB, the drug susceptible TB cases. And also we're reading the facilities that are contributing. It was only not from the 5 sites, but even other sites from the region that were actually sending samples to access the Gene Expert. And you can see over time, the utilization is increasing. And from this, the use of the Gene Expert, we have also picked the MDR cases in the region. For over time, they were, over the last 1 year before our interventions, they had only found 4 MDR cases. And by March this year, they had already 7+ cases that are coming through just by supporting use of the Gene Expert. So from what we have presented, what are the cost implications? From this is what we have supported is within the guidance of PEPFAR, and one of the areas is TB-HIV. And they give the guidance what areas can be supported. But there are other areas, strategic information, health system strengthening, ARVs services, basic care, that are supported by PEPFAR. From the TB-HIV part, that is the money that fits within the PEPFAR funding. That if the national program asked PEPFAR, how much money did you support, did you contribute to the TB programming, we would have reported around $130,000 within the 8 months, and would be reported to the national program. But even when we report that money, from the TB side, the way the costing is done, only 47 would fit to BTB-HIV. The other money goes into program costs like trainings, which are not necessarily TB-HIV. But there are also some system issues, that areas that we were able to support, like strengthening the expert use beyond the training of health workers to use the expert. We needed to have the samples transferred to the Gene Expert sites, and that is laboratory strengthening in HIV work. And already there's another system of transporting samples for early infant diagnosis. This is not money for TB, but it's the same person who can pick samples for Gene Expert and samples for EID. So that cost, we can only use a proportion to actually determine how many of the samples were TB samples transported, which cost will still be made whether you send a Gene Expert or you don't send, whether you send an EID sample or not, or a viral load test. So those are costs that we have actually contributed to TB programming, which may necessarily not be reported to the TB program. But actually, it's funding that is available to the TB program to actually make use of. So from what I've presented, we think that the HIV program in Uganda really is largely funded by PEPFAR. This is an example of one region. We have 12 regions, and in only 6 to 7 months. So if you estimate what other partners have actually supported in the different regions, the 12 regions, the gap could be smaller than what we're actually talking about. And as you could see, there are possible challenges. What I've showed the excerpt that I have, of tracking the resources, but also when they are reported to the national program will say, we have overfunded, this money is too much for the budget for TB/HIV. What did that money, that extra money, what did it do? They are not able to determine that. So allocation of that money in the right areas within TB programming might be a challenge. So there could be a possible overestimation of the financial gap for the TB response. So we need, from here, the conclusion is more efficient gains could be quantified by improving the tracking of resources from the different funding sources. And rationalization of one comprehensive HIV partner in a geographical area results in efficient gains for TB/HIV programming. I've presented this on behalf of the team, and this project has been supported by the President's Emergency Plan for AIDS Relief through the CDC under those terms and conditions. Thank you very much.
Thank you again for another excellent presentation. We have time for some comments or questions for Mary. Yes.
Thank you, Mary. That was very interesting. What would you suggest to the program to sustain such efforts?
I think the partners need, what could I do to say to the programs to sustain such efforts? They need to, I think, provide guidance to the partners on how they can actually integrate the TB programs in the available resources, because there's not much that we have for TB only, but with available resources, more can be achieved. So guidance should be provided to the partners, what they can leverage on what is available already. I think so.
Okay, thank you very much. So the next paper to be presented will be by Masood Alam from India. The title is A Technology-Enabled Social Franchise Approach to Increase Tuberculosis Case Detection and Cure Rates in Urban Patna, Bihar, India. Thank you.
Good afternoon. Actually, I am representing Health Department, Government of Bihar. The paper is based on how can technology increase the detection of TB cases and then cure. The TB scenario of India is it is 2.2 million cases in India, as global evidence is 9.6 million. And estimated TB prevalence of 2015 was 2.5 million. And as India is also the signatory of in-TB strategy and committed to adopt new strategies. And Government of India also revised RNTCP program and added private sector engagement and new initiatives and policy changes. If we talk in the sense of Bihar, in 2014, almost 58,000 cases were detected. And Bihar is one of the states where daily regime is going to be start. In Patna, urban area, we have engaged a private provider interface agency to see that how the urban cases is being, as TB has been notification disease. Objective was the project is that to facilitate early accurate diagnosis of TB in private sector, facilitate notification of cases diagnosed and treated in private sector, ensure appropriate treatment in case of private sector as per national standard of TB care guidelines, and ensure treatment completion and improved cure rates of TB patient in the private sector. This is the model. We have set up a ICT-based call center in the urban area of Patna, and it covers entire urban area. As its focus on urban area, actually RNTCP focuses on rural area basically, and that the project is focuses on urban area. And support services we are given at free diagnostic test Actually, private providers like doctors and chemist shops have been involved in that. Then sputum transportation, free anti-TB drugs through e-voucher system, service incentives to the providers, and call center for adherence tracking, patient household visit by the field teams. We have the volunteers who visit the different households of the patient. And each and every patient has been recorded in computerized system, the data, and the call center follow up with the patient whether they have taken the drugs or not. So it's information based. And as a result, till December 2015, 658 doctors have been trained on this, and informal providers was 719, and total 688 chemist shops have been involved in that. Laboratory and etc. facilities, 148 facilities have been involved. And then case notification as of December 15 was 20,000, and it was notified in the Nischaya. For 20 patients with drug-resistant TB identified, and 18,000 TB patients initiated on free anti-TB drug treatment in private sector, and 8,000 patients successfully completed treatment program. Program is still going on, so we'll see that at the end of that program that whether it can be replicated in other urban areas or not. A conclusion is that the private sector contribution of TB care is huge. Engagement with private healthcare sector imperative for disease control. Collaboration with multi-sectoral partners yields more cases detection and effective diagnosis of TB. An ICT-enabled service adopted well by private providers. Partnership and engagement with PPIs, a viable mode of investment, expansion of TB control measures in the state. So it's a very good example, and other private sectors and government is also appreciating the project. So soon it's going to be expanded in other cities as well. Thank you.
Yeah, thank you very much for that presentation. Question and comments, yes. Really loud if you could. I'm sorry, we don't have a mic.
The presentation is really very interesting. I'm Diana, I'm a consultant of Leprosy in Netherlands, and I was just wondering how you were successfully to engage private sector into this intervention, because in most of the countries, private sector is not really interested to be involved. So I'm just wondering what were the pre-steps of including the private sector in this intervention.
Actually, there is a provision of incentivize. If the first we have trained the private providers like doctors and medical shops and then laboratory technicians, and there is an incentive mechanism in that. If a doctor notify a patient and he diagnosed with the TB, he gets 100 rupees, Indian rupees, and then they send to the laboratory. All the things is incentive based. So there is the motivation to private providers that they identify the patient, send to the laboratory, and if he diagnosed with the TB, then they get the free medicine from the medicine shop. So they get all the reimbursement. So this is the mechanism.
Okay, thank you very much. We have one more paper, and I'd like to go ahead and ask the next speaker to come up. Sripirian Anduragan from India on innovative interventions to enhance access to TB services for vulnerable and marginalized populations, experience from India. Thank you.
You haven't yet? No, I went and confirmed it also.
So the disk doesn't have a file on it?
I have it.
Yeah. Yeah, while they're working on that, I just will make a few comments. Thanks to all the presenters and their colleagues that work with them back in their location to help put these reports together. I think it's been a very illustrative session with, again, very high-level views from the country level and focusing down to the individual clinic and district level to identify where gaps in care can be identified and be rectified. And I think it's a nice example of where we need to be moving globally as we work toward really ending TB, is to identify these gaps and find out what is an effective way of closing those so that the patients out in the community can get the diagnosis and care that they need. Thank you for overcoming a little technical challenge and your help in the back. Thank you very much. Yeah.
Thank you for giving me this opportunity. I'm Dr. Shripriya from the Union, working with the India office. We have a project called Akshaya, so I'm going to actually talk about the two interventions, what we do under Akshaya. So before going to that, what is the need for the intervention? We know in India, TB is the greatest public health challenge. With the recent report coming up, we are increasing millions of 1 million missing cases. So why there's a need for this intervention is basically a low awareness about TB, especially in the vulnerable and marginalized population, and the access to health services is also very poor. And this has led to the delay in diagnosis and further treatment for these TB, presumptive TB cases. So we also need to involve other service providers to improve this delay in diagnosis. Next. Okay. So this is a project which is funded by Global Fund. Akshaya in Sanskrit, it means TB free. So the goal of this project is to improve the access to quality TB care and control services through the civil society participation. So the objective is to actually support the national tuberculosis control program by involving the communities and community-based care providers to improve TB care and control. So we are we are implementing the project. The union is in 300 districts. This is the snapshot of activities what we do. So there is a greater involvement of the community. So we sensitize the community groups, local help, self-help groups, and the Panchayat Raj institutions. And we also have a major component, what I'm going to talk about as an intervention. This is the increased access to TB control services. This is an enhanced case finding. So that I'll be dealing in detail. And we are also involving the rural health care providers who are the first point of care. So that also I'm going to talk about the intervention. And we also created district level TB forums where they are raising the voice of the people and increase the political administrative commitment towards TB care and control. So by these activities, we try to increase the case notification, decrease in the default rate, and thereby improving the treatment success rates. So this is the coverage of the project. The project is in 300 districts implemented by 8 sub-recipient partners. We are actually covering 16 million people through 1,100 non-government organizations, and we have created a cadre of community volunteers, 20,000 community volunteers who are trained to create awareness and to identify the presumptive TB cases. So the first innovative intervention, what I'm going to speak about is the active case finding, what we call as Akshaya Samvad. So Samvad is sensitization and advocacy in marginalized and vulnerable areas of district. So this is a map of what we do before we start this intervention. We identify the pockets of marginalized and vulnerable population who are at most risk for TB. So where there is actually poor access to health services, where there are more slum population and tribals, migrant, HIV population. So we actually target these population, map these population, and then we start our intervention. So we have, as I told, we have a cadre of community volunteers. So these community volunteers, with the help of IEC materials, they visit house to house, and then they talk about TB. Talk to them about the symptoms of TB, and if there are any presumptive TB cases, they refer them. Nearly 1,000 households are visited every month in each district. So when we identify the presumptive TB patients through this intervention, either we refer them to the designated microscopy centers, or wherever the patient is unable to go to the diagnostic centers, we have a provision of doing a sputum collection and transportation. The community volunteer collects the sputum from the patients, and then it delivers it to the diagnostic center, and then the results are being given to the presumptive TB patients. So this is how the intervention works. The results of active case finding from April 2013 to December 2015, we have nearly reached 9 million households through this intervention, and we have identified 590,000 TB symptomatics, and 52% were examined for sputum examination, and 7% were found to be positive, and 97% are on treatment. So the next intervention, what I'm going to talk about, is the training and engagement of rural healthcare providers. So in India, the rural healthcare providers, they are the first point of contact. So for any health problems, the village people, they go to the nearby local health doctors, those who are not qualified. So what we tried to do through this project, we sensitized these rural healthcare providers on TB care and control. We trained them to identify the TB symptomatics and make them refer to the nearest diagnostic microscopy centers. And we also encourage them to do the sputum collection and transportation for those patients who cannot access the health facility. So many of the rural healthcare providers, they are also acting as dot providers. So they also, once the TB patients identified, and then they put on treatment by the National Control Program. So these RSCPs, they provide the dot treatment. So through this project, we have nearly trained 22,000 rural healthcare providers, and consistently 22% of the RSCPs are engaged with the project. So meaning every quarter we get at least these RSCPs, they identify some TB symptomatics, they refer them to the diagnostic facilities. So this is the engagement, number of RSCPs trained and the number engaged. The results of RSCP engagement, if you see, 146,000 TB symptomatics were identified by these 25,000 RSCPs. Out of them, 66% for these symptomatic sputum collection, sputum examination were done, and 12% were found to be TB positive. So it means 20 TB patients are referred by one RSCP, and 2 of them found to be positive. So through this project Akshaya intervention, we find that the two strategies, active case finding and engagement of rural healthcare providers. So this has increased the access to diagnosis and treatment for TB among the vulnerable and marginalized population, and this has resulted in the yield of additional TB cases to the National Control Program, and we recommend that this intervention can be replicated in other TB high burden countries as well. Thank you.
thank you for another excellent paper. I know we're close to, feel free to get up and ask any questions or comments, and certainly if you have to leave for the next session, then go ahead and do so. So I think this is a very interesting look again in the series of reports that we've had. This is really at the basic level of the marginalized population, helping them to understand what the TB symptoms are and helping them access providers in their rural area as well. I guess one question I would have for you, if we really had some very easy to use point of care tests for TB diagnosis and a much more user-friendly regimen, one pill once a day with no side effects like we have for HIV, how much more effective this approach might be?
So India, we are actually piloting this daily regimen, and also newer diagnostic tools are coming up. So this will definitely help in increasing the access to the healthcare services, definitely.
Yeah, okay.
Yeah.
Yes.
What do you feel is the yield of the, this is a gigantic active case finding, door-to-door active case finding.
Yes.
What do you think is the ultimate yield of that? Do you feel like, how are you measuring what the yield is in terms of?
The objective actually, it's not to measure the yield of the program. What we try to do is increasing the access to healthcare services. So the reason why we go to door-to-door is to create the awareness. Even if there are no presumptive cases, when we visit also, they would know where to go. So probably the presumptive TB cases would have gone after the intervention also. No, it's actually more of creating the awareness, and thereby if there are some presumptive TB cases, we are linking them to the treatment control. So there's no, we haven't actually measured, and it is not, it's very difficult also because we are not in the entire district. We are in the district, we are working only in the 2 tuberculosis units. So it will be very difficult to measure our contribution. But the number of cases, if you see, it's actually nearly 60,000 TB patients we have identified through our project. So really, definitely it is contributing to the increase in the access to care.
Yeah, do you have any sense of what percentage increase in case detection this may have resulted in? Obviously it's something you can't calculate, but you have a sense that it's really having an impact in those areas?
We found that the areas that designated microscopy centers, wherever we are working, because we are not covering the entire district. So wherever we are working, we find that Akshaya is contributing nearly 18 to 20%. In some places, 50% also Akshaya's contribution we can find.
Yeah.
So there is an increase in case notification rates.
Okay. All right, I want to thank all the speakers and also for members of the audience as well. And wish you an excellent union meeting as we go forward through the rest of the week. Thank you.